So let's study about pathology. So see this picture, general pathology. The blood cells are two different types, myeloid and lymphoid. So myeloid, they have got monocytes, basophils, neutrophils, eosinophils. These are myeloid group. So monocytes turn into macrophages and basophil, neutrophil, eosinophils. These are phils are granulocytes. Now, if you see lymphoid progenitor, the important is TB, a natural killer dendritic. Then T has got CD8 and CD4. 8, 4. B has got memory, plasma. So this is important. Plasma cell, memory cell, CD4, CD8, TB. It is all in among this. Now polymorph. What do you mean by polymorph nuclear? Monomorphic nuclear. Nucleus is single. Polymorph, you can see the polymorph and nuclear. You can see the nucleus C. Poly 1, 2, 3. Again these 2. So these 3. And in this monomorph is single. Monomorph. So polymorph nucleosides, polymorph nuclear cells, also called as granulocytes. Basophil, eosinophil, neutrocytes. So basophils in the blood is the mast. Basically, it is concerned with the mast cells. Allergy, antigen, IgE, important, allergic, vasodilator. All they are vasodilators, but except serotonin, which is vasoconstrictor. Then eosinophils with parasites. So these two are for allergy. Eosinophils with parasites specifically during allergy of eosinophils. Eosinophil count is increased, basophils with the mast cells. Neutrophils, mature cells already in the blood and tissue and phagocyte up to bacteria, and they are died. Neutrophils are most predominant cells in acute inflammation. This is a cell of inflammation, that is neutrophil. Now A granulocytes, monocytes and lymphocytes. Monocytes, just you have seen here, these are monocytes and lymphocytes. This is monocyte, they convert into macrophages, and neutrophils can phagocytize and monocytes. Immature cells in the blood begin to swell up and called macrophage. Phage means eating. Phagocyte up to 100 bacteria. Then can survive. They get died. Neutrophils die, but they can survive. This is monocytes, myeloid progenitor, and it is lymphoid progenitor, T lymphocytes and B lymphocytes. It is T and B. T responsible for cell mediated against the viruses, and B for humoral immunoglobulins against the bacteria. This is against virus, this is against bacteria. T against the viruses, B against the bacteria, and B is humoral. So just we have to understand this. Against bacteria, humoral, this is virus, and cellular. By transmission, plasma cells, through plasma cells. So immunity are two types, innate and adaptive. The body has got power to fight with the foreign. Innate is natural, adaptive, acquired. Normal defense mechanism, for example, spleen, skin, phagocytic, gastric acid. Then cell mediated humoral. B lymphocytes form plasma cells, immunoglobulins. T mediated T cells, CD4 and CD8. Immunoglobulins are of 5 types, M, G, D, E, A. Gamed. The largest is M. M is largest and first. IgG, most maximum in quantity, and this is maximum in size, maximum size. M, G is quantity, and they cross placenta, second to form. Along with M, it was class switching. D switch to M. E is for allergy. A is present in mucosal and orifices. Class switching definition is by specific and M to D, G, A, E. Infection cellular sequence of formation start from M to G. First M is formed, then G is formed. Major histocompatibility complex HLA, a definition of protein that binds with antigen to present to T cells. Now antigen bind with the to form T cells. Classes of HLA are 1, 2, 3. There are 3 classes. A, B, C present in nucleated cells. DP, DQ, DR is present in beta and T lymphocytes. After operation organ transplant, HLA system is responsible for graft rejection. Most important of these are DR first, then DP, then BCA. What are the disorders of immune system? These can be hypersensitivity reaction, autoimmune disease, immunodeficiency. These can 3 things can about. Now hypersensitivity are of type 1, 2, 3, 4, 5. 5 types of hypersensitivity. Mediators, you just see the mediator mechanism, IgE. So it is again A, EGG, EDG, MMT. Anaphylactic acids, A, C, it is remembered like A, C, I, D, and S. And this is E, G, G, acid X. So acid is anaphylactic. Anaphylaxis. Exposure to antigen for first time causes IgE on the mast cells. Mechanism on exposure, this IgE gets activated causing release of mediator like histamine, and basophils cause allergy. It is in minutes, asthma, hay fever, drug allergy, food, pollen, rubber catheter. Then cytotoxic. Second is cytotoxic. Antigen is component of the cell's membrane causing cell activation of IgG and M. Cell lysis. They cause cell lysis. These are autoimmune hemolytic anemia and ITP anemia. It occurs in hours. Then type 3 is immunocomplexes. Antibodies are formed, react with antigen forming immune complexes, deposit in the base membrane causing destruction. SLE, rheumatoid arthritis and all glomerulonephritis. Then delayed type is antigen stimulates and forming sensitized T cell which produce lymphokine, tissue necrosis, 2 to 3 days, graft rejection, contact dermatitis, latex allergy, tuberculin test. And autoimmune are Graves' disease, myasthenia gravis are type 5 autoimmune. If the patient undergoes manifestation happens on the first or second time he gets rubber, it is considered type 1. While if nurse allergy is type 4. Examples include autoimmune or endocrine, Hashimoto's, these are autoimmune. These were hypersensitivity. First is the hypersensitivity. Second is autoimmune, then immunodeficiency. Now autoimmune, Hashimoto's, Addison's disease, inflammatory bowel ulcerative colitis, SLE and rheumatoid, autoimmune hepatitis, hemolytic anemia. Connective tissue disorder, fat, myocytes, extracellular growth substance, fibrin, elastin, fibrillin. So defects in collagen type 1, type 1, 2, 3 and fibrillin. Fibrillin, this is question in Marfan syndrome, Ehlers-Danlos 1, 3 and osteogenesis imperfecta type 1. Type 1. Then clinical picture, irregular patches of ossification on the X-ray. You see ossification, multiple fractures in child, hypermotility of the joints, dislocation, prolapse of the organ, Ehlers-Danlos, Marfan syndrome. So fibrillin due to mitral valve deficiency present in chromosome 15. So to remember what are the findings, Marfan's aim is mitral valve prolapse, automatism, return fibrillin 1, arachidactyly, pacemaker, lungs. Then third part is immunodeficiency, that is HIV causing disorders in T lymphocytes. Picture is acute phase 2 to 4 weeks, carries for liver then fever, latent phase up to 10 years. Virus keeps replicating in CD4 lymphocytes. Late phase CRR receptive, CR5 reception. This virus received opportunistic infection occurs if CD4 goes below 200. Normally it has to be about up to 800. CD4 count goes below, then patient gets opportunistic infection like Candida, generalized follicular hyperplasia, Kaposi sarcoma, hairy cell leukemia of the tongue. These are the all questions. Follicular hyperplasia, lymphadenopathy, Kaposi sarcoma, hairy cell leukemia, proportion infection. Investigation, ELISA type P24 antigen, CD4 count healthy is 500 to CD4 count below 200 is very risky. CD4 CD8 ratio 1 is to 1. CD4 ratio is less than 1. High viral load more than 10,000 copies is equal to high transmission. So disorders of spleen, massive splenomegaly, GMC, Gaucher's, malaria, chronic myeloid leukemia, other names Niemann-Pick's, Feltis syndrome, rheumatoid hyposplenism, celiac disease, aponeurosis, splenic rupture without trauma is Epstein-Barr virus, and autosplenectomy is sickle cell anemia, Gaucher's. So post-splenectomy conditions, you see Havel-Jolly, this is question, Pappenheimer bodies question, target cells question, contact target question. First blood component to be increased after platelet is increased, granulocyte increased. These are all questions. Overwhelming infections, some super killers have pretty nice big E. coli, strepto, salmonella, influenza, Neisseria. Vaccinations are Neisseria meningitis 1, influenza 2, 3 is streptococci. 2 weeks before and after, booster is 1 to 5 along with the penicillin. What is tissue response to inflammation? How does inflammation occur? It is inflammation, repair, cellular adaptation, intercellular cell death. Inflammation is definition, response, exudate formation. What happens? Acute inflammation, chronic, primary, chronic. Acute is characterized by two main steps: formation of fluid exudate, increase capillary permeability is the first thing, and hydrostatic pressure. Cellular reaction, chemotaxis of the phagocytic cells. This is second. Neutrophils, which are most predominant cells, acute inflammation. Neutrophils, what they could do? Macrophages. Then macrophages appear, monocytes and histocytes. These cells secrete histamine, serotonin, prostaglandin, complement C5A. All are vasodilated except serotonin, which is vasoconstrictor. Steps of phagocytosis: opsonization, recognition and attachment of bacteria which facilitates. This is the question. Opsonization. Engulfment of bacteria is produced. Degradation killing bacteria. Then oxygen dependent is hydroperoxide and oxygen independent lysosomal enzymes. These are the question. Oxygen dependent hydrogen and lysosomal oxygen independent. Group of proteins that is activated by cascade by the antigens. Complement is, this is proteins that is cascade by antigen. Bacteria supposed to kill bacteria and remove the dead tissue. Help in complement C5A C3. Opsonization important. Complement opsonization C3b. C3b for opsonization. Bacteria may survive in the microbial awaiting later activation. Fate of acute inflammation: complete resolution, regression, spread, chronicity. Chronic inflammation, it may be primary or secondary. Common occurs in primary inflammations are sarcoidosis, tuberculosis, ulcerative. Secondary is because of cholecystitis, Arshoff nodules. Main cells of chronic inflammation: macrophage. This is giant cell formation, granuloma. Microscopic fibrosis, ulcer, granuloma. Granuloma, the particular form of chronic granular inflammation, considered macrophages and cluster of lymphocyte giant cell necrosis. Types of granuloma: infectious, tuberculosis, encephalitis, and foreign body granuloma, surgical sutures. Tuberculosis, organism microbe tuberculosis, Zn staining, Lg media, swelling of raw milk. And then neutrophil engulf the bacteria but cannot digest them because it lacks a lipase enzyme. Lipase enzyme is not present, so die rapidly. And macrophages engulf the bacteria and can digest the bacteria. They cause alteration of microbiome, become swollen epithelioid cells. Epithelioid cells may fuse together from large complex Langerhans giant cells. T lymphocytes are synthesized by altered macrophages releasing lymphokines which cause caseation necrosis of tubercle. Type 4 hypersensitivity. Most abundant cells in the tubercular granula are macrophages. Localization: with adequate immunity, small lesions are replaced by fibrosis, spread failure localization. Primary tuberculosis, first time mainly affects in children, secondary reactivation. Sites, Gons focus, which is seen in the lung, upper lobe, hilar lymphadenopathy is there, secondary cerebral lesion, both apices, lymph nodes matting together, cold abscess, vertebrae. Sarcoidosis, tuberculosis may extend muscles, recurrent abscess formation. Sarcoidosis, what about sarcoidosis? The systemic non-case eating granuloma. This is question. Asteroid bodies. Facial nerve palsy. This one is question. Most frequent neurological sarcoidosis. Bilateral 80%. Bilateral non-tender parotid enlargement is the question. Xerostomia is the question. Hilar lesions is the question. Hypercalcemia again is the question. Facial parotid bilateral treatment resolves spontaneously without treatment. Other infections, actinomycosis, snake formation of multiple tracts, sulfur granules. This is the question. Chagas disease, stepanocrosis from achalasia. This is the question. Infection, nitrofuramax. Tissue repair, wound healing, hemostasis. What are the in minutes? Hemostasis, plug is formed, vasospasm occurs. First is vasoconstriction, vasospasm, plug, platelet, RBC. Second, 1 week inflammatory response, neutrophils come first, then macrophages, fibroblasts replicate. 1 to 6 is formation of new scars, endothelial, fibroblasts, macrophages. Myofibroblast after 6 weeks, remolding. Causes of impaired immune healing did not heal. Diabetes, infection, drugs, all these did not heal. Jaundice, complication of wound healing, hypertrophic scars, keloid. Keloid is beyond boundaries, it is limited to boundaries. Wound dehiscence, reopening of the wound after healing. Specific form, bone healing, hematoma, 1 week, then callus, fibrocartilage callus, then bone callus, 6 to 8 weeks, remolding, 8 years together. Fracture healing, callus healing. Nerve, it is neuropraxia, axonomatosis, neuromatosis. Neuropraxia is just impaired valent degeneration does not occur. Valent degeneration. Axonomatosis, this occurs, it repairs. Start 3 days after injury and axon degeneration starts. Small nerve defect 1 millimeter per day. Mortis neuroma is wearing tight pointy shoes. Intercellular and extracellular amyloid deposition. Extracellular deposition of amyloid, which is starch-like substance, reacts with iodine to give blue color. Amyloid light chains, immunoglobulin secreted by the plasma cells. Amyloid associated, amyloid light, AL is amyloid light. Amyloid associated protein, AA, secreted by plasma cell. Non-immunoglobulin protein secreted by liver. And beta 2 microglobulin, prealbumin. Type of protein, AL protein, abnormally lymphocytes, multiple myeloma, AL, and AA is chronic obstructive tuberculosis, and beta 2 is the renal microglobulin, renal. Cardiac amyloidosis, transthyretin. Microscopic staining, HNE staining, green bipolar, Congo red staining, green bipolar refulgence polymerase light. And Persian blue, hematochromatosis. Pathological classification, deposition of calcium. Pathological calcium in other sites other than normal. It is also called as metastatic calcification. This is metastatic and this is dystrophic. The tissue becomes hard and chalky. Most common type is dystrophic calcification of the dead tissue or implant despite fat necrosis, breast implants, and metabolism. Second most common calcification of normal tissue due to hypercalcemia, hyperparathyroidism, malignant bone destruction. So cell death may be physiological, pathological, apoptosis, necrosis, physiological, shrinking, cell membrane, nuclear fragmentation, and killing the pathogen. And this is necrosis of the caseation necrosis. Types of necrosis: coagulative, brain pus coagulative, colligative, and coagulative is myocardial infarction. Caseation is tuberculosis. Fibrinolysis, malignant rheumatic arthritis. Fat necrosis, breast. Gangrenous ischemia. What are the growth disturbances? This can be agenesis, aplasia, hypoplasia, failure to development, absent kidney, aplasia, rudimentary kidney, hypoplasia is atrophy, shrinkage of cell, hypertrophy, size of cell, hyperplasia, number of the cells, metaplasia, transformation 1 to a barrel squamous stratified to columnar epithelium with Gorbet cells. This is the question. Precancerous leading to esophagus, cleoplagia, white patch, hairy leukopenia affects immunocompromised AIDS, hairy leukopenia, erythroplakia, squamous metaplasia and plagia in the smokers. So atrophy, myosynapse trauma, dysplasia, disorder, cell death, and precancerous. Neoplasia is a tumor. So there are two types: etiology, oncogene, and tumor suppressor. Oncogene derived from the mutation of natural genes, proto-oncogenes causing tumor formation. Autosomal dominant, cis, Mike, APC, BRCA1, BRCA2, and P53 gene that prevent so adenoma APC is adenoma gene mutation. Mm, Normal cell hyperproduktion, alter-adenoma, intermediate adenoma, late adenoma, carcinoma. This is called sequence, adenoma, carcinoma sequence. KRAS mutation, DLC gene, P53 others. Autosomal dominant gene means that the individual one copy of the chromosome normal gene on the other chromosome, if is mutated, it can cause effect. That is autosomal dominant. Autosomal recessive individual has two copies of mutant gene, so both copies exert the effect. Double hit theory. So this is coma. Autosomal recessive is coma, cystic fibrosis, osteoporosis, mycosis, sickle cell anemia. Oncoviruses, the viruses which can lead to malignancy. These are EBV, Epstein-Barr, Burkitt, Hodgkin, Naso, HBS, afflicted, hepatocellular, HIV, Kaposis, HIV and HBS, human papilloma 1618, vulval cancer, penile cancer, and all this. H. pylori, malt, beta naphthalene, bladder, asbestosis, mesothelioma, angiosarcoma, PVC. Characteristics: loss of architecture, pleomorphism, increased mitotic activity, dense chromatin, prominent dark nuclei, increased nuclear cytoplasmic ratio. Now, what are the tumor markers? Testicular tumor alpha beta, liver cancer alpha beta, prostate cancer PSA, lung cancer CA25, breast cancer CA15, stomach CEA, colon, pancreas 19, venal mandric carcinoma tumor most sensitive 5HJ. Classification of tumors: lipoma, papilloma, leiomyoma, desmoid tumor, benign, locally malignant basal cell carcinoma, osteoclaustoma, carcinoid tumors, malignant squamous cell carcinoma, adenocarcinoma from the columnar epithelium. It may be seen sarcoma from mesenchyma and melanocytes, other teratoma, hematoma, lymphoma. Now sarcoma, these are the bone are called osteosarcoma, Ewing sarcoma, chondrosarcoma, soft tissue, liposarcoma, rhabdomyoma sarcoma, according to site, extremities, strength, according to spread, blood spread, lung, brain, liver, smoke, according to some types of sarcoma, lymphatic spread, rhabdomyosarcoma, and race for MS. Malignant fibrous histocytoma, sarcoma in adult, sarcoma in pediatric, rhabdomyosarcoma. Second most common sarcoma is liposarcoma, encapsulated retroperitoneal PDRS, sarcoma and swelling, painful deep muscle, teratoma, complex from three germ layers, include ordinary gonads, testes, and extragonadal, mature teratoma, benign teratoma, immature teratoma, struma ovary, teratoma of the ovary, lung tumors, non-small cell cancer, small cell cancer. Adenocarcinoma is non-small cell, adeno. At 40% in the lung tumors common. Common is adeno. Second is squamous cell carcinoma, occurs in non-smokers. Slow, centrally located squamous, paraneoplastic syndromes are very common, especially PRP, where increased CA level. Large cell and small cell smoking is very common, paraneoplastic very poor. Mesothelioma is type of cancer, tissue covering the organs. Layers of tissue covering the organs. Lung is the most common, abdomen, heart. The most common important exposure to asbestos, 15 to 20 years, genetic predisposition, shortness of breath, is generally resistant both to radiotherapy and chemotherapy. Early diagnosis may be treated with resection. Lymphoma, type of cancer from B lymphocytes, A symptom lymphoma, cough, hematosis, beta, P Epstein fever, network, pathology, presence of red Steinberg cells. Nodular sclerosing is most common, lymphocyte depleted. Worst prognosis, lymphocyte depleted, classical mixed cell nodular lymphocyte breakdown. Diagnosis and staging, diagnosed by extra biopsy of the lymph node, chest and abdomen. Staging, single lymph node on two or more lymph nodes, involvement on both side diaphragm, involvement extra lymph nodes. Hodgkin's and non-Hodgkin. Hodgkin's is Beta lymphocytes is Hodgkin and non-Hodgkin beta as well as T lymphocyte, MALT and all this. Post-thyroiditis, non-Hodgkin lymphoma. Bimodal, nodal mainly, extranodal, good, poor. Non-Hodgkin is poor. Differential diagnosis of cervical lymphadenopathy in some cases. Nasopharyngeal carcinoma, most commonly in China, Hong Kong. Epstein-Barr virus is cervical lymphadenopathy, nasal discharge, tubular cervical biopsy taken for granuloma. So this was about the pathology.